You've spent years in the classroom building your knowledge base, but now you're on the edge of the ward. It's 3 a.m., the clinic is slammed, and you have minutes, not hours, to make a decision. In these high-pressure environments, EBM is frequently dismissed as cookbook medicine, a rigid set of protocols that supposedly ignore the specific nuances of the patient in front of you. If you treat EBM as a simple recipe book, your hard-earned clinical judgment feels irrelevant, reducing your role to checking boxes on a pre-written list. The historical roots of EBM tell a different story. In the 1830s, Pierre Louis used numerical data to prove bloodletting was ineffective. John Snow mapped cholera outbreaks in London to pinpoint contaminated water. They used systematic observation to challenge entrenched, ineffective traditions. True evidence-based medicine is the antidote to rigid, outdated habits. It is a framework designed to guide your judgment, not replace it. The modern standard was set by Dr. David Sackett, who defined EBM as the conscientious, explicit, and judicious use of current best evidence. Pay attention to the words judicious and individual patients. The evidence provides a map, but you must actively navigate it for the specific person in your care. This chart shows EBM's 3 pillars: research evidence, clinical expertise, and patient values. Practice collapses without all 3. The center overlap is where an actual evidence-based decision occurs. Relying on just one pillar treats a statistic, not the human being. We start with best available research evidence. EBM does not value only randomized controlled trials. While RCTs are powerful for testing treatments, different clinical questions require specific study designs. You evaluate diagnostic accuracy with cross-sectional studies, and you use cohort studies to track long-term prognosis or harm. Suppose you are evaluating adults with newly diagnosed type 2 diabetes. You need to know if metformin, compared to lifestyle modifications alone, will better control their HbA1c levels over 6 months. This chart shows how easily data can be misinterpreted. A 50% relative risk reduction sounds impressive, but if the baseline risk drops from 2% to 1%, the absolute risk reduction is only 1 percentage point. This is why you must calculate the number needed to treat, or NNT, the actual number of patients you must treat to prevent one bad outcome. If the NNT is 1,000, the intervention might be statistically significant on paper, but practically questionable given the potential side effects and costs for an individual. Research evidence provides the mathematical probability. Expertise is required to determine the significance of that probability. Clinical expertise is the ability to rapidly identify a patient's unique health state, their individual risk profile, and specific comorbidities. Watch what happens to the model when you remove your clinical expertise. The remaining circles disconnect. Consider taking pristine trial data gathered from a strictly controlled study group and applying it directly to an elderly patient managing 5 chronic diseases and multiple interacting medications. Your expertise acts as the filter. It allows you to recognize when the study population in the literature simply does not match the physiology of the patient in your exam room. Research without expertise results in treating guidelines rather than human beings. The third pillar is patient values and preferences. This includes their unique concerns, fears, and expectations. If we drop this pillar, you can execute a methodologically flawless decision that fails the patient entirely. An aggressive treatment protocol designed to maximize life extension might perfectly align with the data, but it is the wrong choice for a palliative patient who prioritizes being comfortable at home. EBM facilitates shared decision-making. The data informs the conversation, but the patient's voice shapes the outcome. An intervention is a success only when it aligns with the patient's individual definition of a meaningful outcome. Balancing these pillars daily requires a structured process that can be applied at the bedside. This flow diagram illustrates the 5-step process of evidence-based medicine: ask, acquire, appraise, apply, and assess. The cycle often fails at step 1. Many clinicians recognize their uncertainty, but fail to format it into a specific, answerable question. This chart outlines the PICO framework: population, intervention, comparison, and outcome. Defining your population precisely ensures you don't waste time on thousands of irrelevant search results. The comparison element is vital. You must always identify an alternative to the intervention, even if that baseline is just standard care or doing nothing.
You can adapt this structure to fit the scenario, adding a T for time if duration matters, or switching to population and diagnostic test if you are searching for a diagnosis. A structured question dictates exactly what kind of evidence you need to find, eliminating hours of unfocused searching. Literature searches only become time-consuming when you start with unfiltered raw data. Navigating the levels of evidence effectively keeps your clinical work efficient. This diagram maps the evidence pyramid, ranking study designs from expert opinion at the base up to systematic reviews at the peak. Notice the distinction between unfiltered information, like individual randomized trials, and filtered information, which includes guidelines and systematic reviews. When time is short, start your search at the top of the pyramid. Pre-appraised resources have already done the work of evaluating the raw data for you. Bedside EBM is about finding the highest quality pre-appraised answer, not repeating the researcher's work from scratch. Step 4 of the cycle is apply. This is where theory meets the bedside. Look back at the integrated Venn diagram. That center overlap, the evidence-based clinical decision, is the goal of the entire process. This fusion is the actual practice of medicine, taking population data and tailoring it to a unique human story. Roadblocks like resource limits or system resistance are real, but EBM provides the tool to navigate these constraints ethically. Applying EBM means striking a balance between the best available data and the human connection. Medicine is dynamic. The evidence will evolve, and your own expertise will grow with experience. This brings us to the final step: assess. Evaluate your outcomes and refine your clinical radar for future questions. As tools like precision medicine and AI become more prevalent, you will still need these foundational EBM skills to evaluate the recommendations they offer. How will you use this data while connecting deeply with the unique human being you are caring for? Integrating these 3 pillars ensures that your practice remains responsive to the latest science while remaining anchored to the individual needs of every patient.